As many of you know, in 2015, we launched MyLymeData, our patient registry and research platform, and we now have over 12,000 patients enrolled. It's one of the largest observational studies of Lyme disease ever conducted, and actually one of the largest patient-driven registries in the nation. So it's a rather remarkable achievement. And we have patients enrolled from every state in the nation and have collected over 2.5 million data points. When we were pulling together some of the descriptive statistics for this report, actually, I found that there were some things that just stood out to me and surprised me. So first of all, 70% of the people in the registry were not diagnosed until they had late Lyme disease. And that surprised me because I thought perhaps people had been diagnosed early and had failed early treatment. But mainly the people who are in the registry are people who are diagnosed late. And that means that we have a really big problem in terms of early diagnosis, but it's also this extraordinary opportunity to improve that statistic and reduce the number of people who develop chronic Lyme disease by treating them earlier when treatments are more effective. Second, 60% report that they have co-infections, and that means that the risk of having a co-infection may actually be a risk factor for developing chronic Lyme disease. Third, most of the patients in the registry have positive serology. For almost all of these patients, that includes some form of Western blot. And now to be eligible to participate in the registry, you have to have been diagnosed by a clinician or report that you've been diagnosed by a clinician. So that, together with a high rate of people who are testing positive on the Lyme test, provides validation that those who are in the registry in fact do have Lyme disease. And fourth, most of the patients in the registry are still taking far too long for diagnosis. So 51% say that it's taken them 3 years to achieve diagnosis, 53% have seen 5 or more clinicians, and actually the number of people who are diagnosed within the first critical month is 12%. So clearly we can do better on that statistic. And before we get too deep into the weeds here, I want to point out that we've been conducting patient registries using patient-generated data for over 10 years. So we've published our first study on access to care in 2011. In 2014, we published our quality of life study, and this year we published our first study using registry data. And I'm going to describe some of the findings that we had during putting together the descriptive statistics. And some of these findings, I think, suggest that there are certain factors that may be suggestive of having a delayed diagnosis. So why are patients developing chronic Lyme disease? We have 70% of the patients in the registry report that they were not diagnosed too late. Why was that the case? And sometimes we hear that patients with chronic Lyme disease are suffering from no more than the aches and pains of daily living. And this chart is from one of our previous studies, and Jen Mankoff was also a co-author on that, as was Ray Stricker. Basically what we found was, and a number of other studies have found this too, was that the quality of life for patients who have chronic Lyme disease is very poor. So much worse, for example, than patients with MS, diabetes, or congestive heart failure. And this quality of assessment standard, by the way, is one that the CDC uses, so it's a standard question. It's used in clinical trials quite a bit, the SF-36. So this puts in perspective how ill patients are. And this is from the same study, and what it shows at the bottom is it looks at the number of bad physical days, bad activity limited days, or bad mental days. And the orange balls are the Lyme patients, and the blue balls are the general population. And we're able to make that comparison between the general population and Lyme patients because, again, this is a government question. So they ask this question on their general health surveys that they do annually, and they ask it of many different diseases. But if you look, for example, at the bad physical days, you can see that for Lyme patients, they're reporting in a month 20 bad physical days. compared to, say, 3 days for the normal population. So that's really quite a big difference in terms of how this population is doing. It's not remotely like the general population. So let me tell you a little bit about phase 1 of MyLymeData. And this table up on the left, it describes who our sample is. So we started off with 4,700 patients, and then we eliminated patients that were not from the U.S. or patients who hadn't been clinically diagnosed by a healthcare provider. And that brought us down to a final sample size of 3,903. And of those patients, 3,556 identified themselves as being ill, and 347 identified themselves as being well. And we ask a lot of diagnostic validation questions. You can see those down at the left. So, were you diagnosed by a clinician? What were your signs or symptoms? What was your exposure? Do you recall a tick bite? Did you have an EM rash? What were your lab test results? Do you have co-infections? And we ask about functional impairment as well. And over on the right side, you'll see that the percentage of people who were diagnosed by a clinician, it's required to be in the registry, were 100%. The percentage that recalled a tick bite was 41%. The percentage that recalled an EM rash was 34%. The percentage with supporting lab tests was 78%, and 60% reported having one or more co-infections. Quite a mixture of people who are involved in the registry. Most of the patients have chronic Lyme, that's 61%. About 18% said they had late untreated Lyme, and early Lyme disease was 6%, don't know or other was about 15%. Most of the people in the registry are females, about 83%, and we're going to talk a little bit later about why this population with chronic Lyme disease might be more inclined to be female. And then the final point to make about the people in the registry is this is a highly educated population. Almost everybody has some college. So one question we asked patients was whether they recalled having early symptoms. And 74% reported that they did have early symptoms. Yet 70% were not diagnosed until late stage. And that's the diagnostic gap we need to close. This is what the CDC would call a winnable battle, but you have to try. You have to identify why patients are not being diagnosed early, and you need to fill those gaps. And as we go along, I'm going to point out some places where diagnostic errors may occur. So one issue may be that early symptoms that Lyme patients in the registry are reporting are not necessarily what physicians are looking for. For example, only 34% of patients reported having the rash, and when you compare that with 64% who had flu-like symptoms, or 44% who had headaches and neck stiffness, you can see there's really a predominance of these other symptoms are much more common. And John Alcott out of Johns Hopkins has pointed out in one of his papers that 54% of patients who do not have a distinctive rash are not diagnosed correctly. So this is obviously one big issue. And late diagnosis may be a predictive factor for developing chronic Lyme disease. And not having a rash in particular may be one of the factors that weighs in on whether somebody is likely to develop chronic Lyme disease. So most of the patients in the registry report that they've had positive lab tests supporting their diagnosis. That's 78%. And note that 45% roughly are CDC positive on either two-tiered or by a standalone Western blot. And as shown here on the top bar, 35% have a positive Western blot that's being interpreted by a standard other than the CDC standard. And my guess is that most of these patients are being determined to have a positive test based on a study by Moss some time ago that uses fewer bands in their criteria. And many of the patients in the registry report having co-infections, 60% in fact, report having co-infections with another tick-borne disease in addition to having Lyme disease. Patients often report having more than one co-infection, so these co-infection percentage overlap. The ones that are in the dark blue indicate patients that had positive serology supporting their co-infection diagnosis. The light blue are patients who did not have positive serology for their co-infection. My presumption is that those patients were clinically diagnosed based on signs and symptoms. So the number of co-infections is really quite high in this population, which is primarily chronic Lyme patients. It's far higher than you would see in an acute Lyme population when you read some of the studies that have been published. And so one of the inclinations from this might be that co-infections may be a predictive factor for who goes on to develop chronic Lyme disease. And most of the patients with chronic Lyme disease report that they were initially misdiagnosed with another condition. And note that a majority of those misdiagnosed report that they were misdiagnosed with a psychiatric illness. But only 18% report that psychiatric symptoms were among their worst symptoms. So that's quite a disparity. Other conditions include most diseases that have no hope of cure. So that would be, or known etiology. So that would be fibromyalgia, chronic fatigue, MS, and so forth. And patients diagnosed with these types of illnesses, they may be put on palliative care, which is, treating the symptoms rather than trying to address the underlying cause. And that may make a big difference. These patients who are misdiagnosed will likely be delayed in terms of getting an accurate diagnosis, and they may be put on medications that have side effects that adversely affect them. This slide is showing the types of symptoms that chronic Lyme patients report having in large numbers. So pain is reported by 71%, fatigue 62%, sleep impairment 20%, psychiatric 18%. And below that chart, you can see that there's a list of different medications that are given. And this, again, is from a government question. So we have government data on the general population. So, for example, in sleep medications, you can see that the general population, maybe 7 or 8% are taking sleep medications. But in Lyme disease, it's closer to 34%. The same sort of disparity exists with thyroid, antidepressants, and prescription pain medications. So another thing that we looked at was symptoms. And a lot of times we'll say that fatigue is the #1 symptom for Lyme disease, but it really depends on how you break these things down. So if you combine all the neurologic symptoms, for example, what you see is that 84% of patients report having some type of neurologic symptom, and that's far higher than fatigue, which is 62%, and musculoskeletal is just 57%. This is how we actually did the breakdown for the symptoms that were deemed to be neurologic, and Dr. Stricker helped me with this breakdown. But it shows which ones: cognitive, neuropathy, sleep impairment, psychiatric, headache, memory loss, and twitching we put in the category of having neurologic symptoms. We frequently hear that people with Lyme disease are all taking antibiotics, and that's simply not true. Only 52% of those who are ill are taking antibiotics, and only 5% of those are taking IV antibiotics. So really the numbers are far smaller than you would expect. The most common oral antibiotics are doxycycline, which is 34%, Zithromax, 22%, Biaxin, 12%, Ceftin, 12%, Plaquenil is 12%, rifampin is 11%, and Flagyl is 11%. Of intramuscular medications, and only about 3% of the patients in the registry report being on these. The two leading ones are Bicillin, 64%, followed by Cleocin, 20%. And of the IV medications, the most commonly taken are Rocephin, 56%, Zithromax, 16%, Flagyl, 11%, and clindamycin, which is about 7%. So patients who aren't taking antibiotics have a lot of reasons for not taking them. It's one thing to choose not to take antibiotics for personal reasons, but it's quite another to not be able to obtain them because you have no access to treating physicians, as 26% report, or because your insurance company won't pay for them, that's 18%, or because the cost is simply too much for you to bear, which is 14%. So access to antibiotic treatment is a big issue, as is the lack of insurance coverage. 50% report that their providers do not accept insurance. So those factors have a big impact on patients' ability to obtain the care that they need. And the last thing I want to point out on this slide is 95% of patients report that they're diagnosed by primary care clinicians. Only 5% are diagnosed by infectious disease specialists. And when you take a look at what's going on in the Lyme environment and you see that the IDSA guidelines are holding such a tremendous amount of weight in the ability of patients to get diagnosed and to be treated, that disparity is really great. So you have very few people setting the rules for very many people is what that boils down to. And as I mentioned earlier, we published our first study using data from the registry. Myra and Jen were both co-authors on this study. And what we were looking at was whether patients varied in their response to antibiotic treatment or whether they all tended to respond the same. So most of the studies of Lyme disease report on average treatment response. That looks at how people do on average rather than looking at subgroups. And in fact, most of the studies on Lyme disease have been too small to look at subgroups. They've had samples between 37 and 129. So you can't do subgroup analysis when you're dealing with a sample that size. But our sample was about 3,000, and so we were able to actually take a look and see how patients varied in their treatment response. And you'll see 52% reported that they were better since they've been taking antibiotics. I mean, we asked a very simple question. We said, since you've been treating your Lyme disease with antibiotics, would you say you're better, worse, or unchanged? Of the people who said they were better, we then blew that question out and said, well, how much better? Just a little bit better or a very great deal better? And so that was an 8-point scale for that question. And the same thing with worse. We asked the same thing. But you'll see most patients reported they were better, 52%. People who were worse was just 12%. About a third were unchanged. And of the people who were better, roughly it was 35% of the people said that they were moderately to a great deal better. That's really quite a high treatment response there. So down at the very bottom, what I've got is, that's a little scale that the 0 would point to no treatment effect. And the average treatment effect that we found was 1.7. So 1.7 on a scale that goes to -7 to +7, 1.7, that's a little bit better, nothing to write home about, right? But the high responders, that was actually 5.3, so 5.3 out of 7, that's actually quite a large treatment response. And when we looked at the people who were non-responders or who hadn't done well on medication, that was just -1.1. So you can see that breaking this down into subgroups and identifying the high responders and what it is about them that might make them high responders would be something to be really important for informing how you might want to treat patients. Many patients are using alternative treatments. Roughly 70% are using alternative treatments either alone or in conjunction with antibiotics. And patients who elect to take alternative treatments either do this by choice, as I pointed out earlier, or because antibiotics are not available to them because of access to care issues. 31% report using alternative treatments exclusively to treat their disease. And so the most effective alternative treatments noted were herbal protocols, while the least effective was stem cell, which was at only 3% of the people who had tried stem cells, and we had a sample size of about 300, which is kind of amazing, reported that it was effective. And by the way, this chart is an interactive chart. It was created for us by Steve Wexler. We're very grateful to him for doing that. And it's available on our website, but you can go to any one of those items that's listed there and click on it, and it'll pop up and give you full information on how many people tried it, how many people found it effective at different levels, and how many people were reporting side effects on it. So I want to conclude by asking the question, why do patients develop chronic Lyme disease? And here are some of the factors that I developed and mentioned during this presentation. One is the presence of co-infections. A lot of patients in MyLymeData report co-infections. Are these making their condition worse, harder to treat, or more intractable? At the beginning of this presentation, I noted that 70% of the patients in MyLymeData report that they were not diagnosed until they had late Lyme disease, that is, 6 months or later after symptom onset. Is delayed diagnosis a factor? We think so, but how big a factor is it? We need to find out, and we need to reduce the time to diagnosis for patients with Lyme disease. Another factor I think is important perhaps is diagnostic delays caused when patients do not test positive using CDC testing criteria, because a lot of the tests that are out there are based on CDC criteria, and a lot of those tests return false negative. In fact, roughly 50% of those are false negatives. And more specifically, I'm talking about the use of overly restrictive banding criteria on the CDC Western blot and the insensitivity of the ELISA. Not being from the Northeast, where Lyme is on the radar for clinicians, may also cause diagnostic delays, because Lyme disease may not be included in the differential diagnosis of the physician at the first office visit. Not having a rash may be another reason patients aren't being diagnosed early. And finally, I'm going to mention being female. We don't know the effect that being female has, but Jen has offered to lean in on this and help us try to figure it out. We think it may actually have quite a role in it. Most patients in the registry are female. Do gender differences affect diagnostic test results? The presence of a rash, immune response, or treatment response? Are Lyme disease symptoms of females more readily dismissed by physicians, resulting in diagnostic delays? These are all important questions that we need to address. So let me close today by saying that if you have Lyme disease or know of someone with Lyme disease that is not enrolled in MyLymeData, please enroll today by visiting MyLymeData.org. If you would like to download a copy of the 36-page MyLymeData highlights report, go to LymeDisease.org. And of course, this work can only be done with the support of patients like you. If you are not a member of LymeDisease.org, please consider making a donation and becoming a member of this vibrant community today. Thank you for your time.